Good evening, everyone. I am Dr. Manish Mahajan. I head Medical Affairs for Zydus. On the behalf of Gastrohepato Research Foundation and Zydus Bionet, the makers of Bilipsa, invite you for the rendezvous on NASH with GI expert. As we all know that we are nearing the International NASH Day, which is falling on 10th of June, 2021. It's a great time to remind us all that within the pandemic of COVID, we are also in the big pandemic of NASH. As we all know, that Zydus Bionex is one of the pioneers and front runners, not only in the management of NASH in India and globally, but also we are engaged and providing a lot of patient educations in the form of NASH 24/7 and have been associated with various international bodies of repute like the Global Liver Institute. Keeping our philosophy of putting patient first, I request each one of the attendees to please take this pledge on this World NASH Day that we'll come together and fight this dreadful disease, which is often silent but very, very dangerous in long term. As you all know, that Bilipsa is the only approved drug in the management of NASH globally and in India, and has been well acclaimed in through the various publications in the national and international journals of repute and the conferences alike. And the drug has been approved in the other indications since 2013 with the patient experience of more than 10 lakh patients in India. The drug has been approved in the management of NASH in the year 2020, and this year we're getting an additional approval in NAFLD with comorbidities. With this, let us begin the key sessions of the day, and I would like to invite the chairpersons for the meeting, Dr. V.D. Maheshwari. He is the Professor of Medicine for SMS Medical College, Jaipur. Dr. Pushpendra Garg, the Senior Consultant Medicine, Jaipur Hospital, Jaipur. And Dr. Puneet Saxena, Senior Professor, Department of Medicine, SMS Medical College, Jaipur. And with this, I request Dr. V.D. Maheshwari to please give his wisdom in the form of few words on the importance of NASH. Dr. V.D. Maheshwari.
Good evening, friends. It's really a great chance from Gastrohepato Research Foundation, and especially my friend Dr. Ramesh Suprai, who asked me to be with you this evening. It's very important. NASH is a very, very important topic. NASH is coming up in big way. We are finding increasing incidence of diabetes mellitus and metabolic related disorders in our daily practice. It's tremendous increase, and it is increasing all around. NASH has another important problem related to insulin resistance syndrome. And this is another silent killer. We used to listen to silent killer as hypertension used to be silent killer. Dyslipidemia used to be silent killer. But now we have another very, very important metabolic killer, that is NASH, and which is not recognized clinically, largely by all group of practitioners. So it's very important that we must understand the problem, and we must break, very rightly it has been pointed out, that we must break our silence, break it loudly on NASH. So I invite Dr. Ramesh Suprai, who is moderating the session, to start this panel discussion, which consists of very learned and seasoned and senior speakers of gastroenterology from Rajasthan State. Thank you so much. Dr. Suprai, please.
Good evening, friends. It's indeed a great evening when we all are together on one forum to discuss about a very, very important disease. The disease is really not a disease, but encompasses lot many things in it. It's a small word, NAFLD or NASH, but it is having a lot of impact on the quality of life and on the morbidity and mortality of the individuals all over the world. It's a smoldering disease, and it is slowly eating the liver and other organs of the body. So today, I am extremely delighted to have Dr. V.D. Maheshwari sir, Dr. Pushpendra Garg, and Dr. Puneet Saxena as the chairman for our this discussion. And I have got a elite panel of my friends, Dr. Sandeep Nijavan, Dr. S.S. Sharma, Dr. Rupesh Pokharna, Dr. Anurag Govil, Dr. Mukesh Kalla, Dr. Sunil Dadhuj, and Dr. Amit Mathur as the eminent panelists to discuss about this problem. As we all know that in clinical practice every day, we have patients who come to us with a something like this, like a 40 years businessman executive in IT firm, chief complaint of fatigue gradually increasing, right upper quadrant pain for 8 months. On examination, ultrasound shows hepatomegaly with grade 3 fatty liver. It's incidentally detected fatty liver. And we have an extreme other end. This is a story of one of my friend who is a doctor. His known case of type 2 diabetes, history of obesity, BMI 28, presented for the first time as melena, sudden passes of black tarry stool, syncope, distension of abdomen, ascites. He was HbS Ag negative, C negative, no alcohol ingestion, and he had a full-blown cirrhosis, features of portal hypertension, ascites, and growth varices, and signs of recent bleed. So you have two extremes of the disease in front of you. And both of patients have underlying non-alcoholic fatty liver disease or NAFLD as etiology. They have fat in their liver, which has progressed gradually and has resulted in the fatty liver disease, which encompasses the entire spectrum of the disease, like fatty liver, NASH, NASH fibrosis, NASH cirrhosis, and of late can go for HCC. To diagnose this condition, you have to have some negative points, that a patient is not drinking alcohol in a significant amount. There is no other cause of hepatic steatosis, no other cause of chronic liver disease, hepatitis B and C, autoimmune hepatitis, or what we call as the other diseases which can be there. Only thing is there should be fat in the liver, and that is going to decide whether this patient is progressing or not progressing. So we know that NAFLD NASH is throttling the whole world like a pandemic. So we have to get alert, as we are doing for COVID-19. We have to get alerted for this disease. Yes. So I would like to ask Dr. S.S. Sharma Sahab that how frequent is this problem? What is the prevalence of this entity all over the world and India? May I request everybody to mute their mic so that we don't get a sound. Dr. Sharma Sahab, please.
Well, it is very difficult to give the exact estimate of prevalence of NASH throughout the world. According to a rough estimate, it is suggested that 25% of the world population is having NASH. As you see on this presentation, that varying from 13 to 30% people have got NASH according to different regions of the world. So on an average, 25% people in the whole world, they have got NAFLD, not NASH, NAFLD. And the prevalence of NAFLD is much more in obese patients, diabetic patients, and patients with metabolic syndrome. There are few studies from India that they have tried to see the prevalence of NASH. One study by Amrapurkar from Bombay in 2007, which was published in Annals of Hepatology, where they have found that around 18% patients, adult patients, they did survey in the railway employees, and they found that 18% people have got NAFLD. Another study done in patients with diabetes, which was published in Japan 2013. It was called SPRINT trial, where it was found 60 to 70% patients with diabetes, they have got NAFLD. And another study from the Cuttack, Dr. S.P. Singh, that they have shown that relatives of the patients, attendants of the patient, they were screened, and it was found that around 24% of these patients were having NAFLD. So overall in India, around 32% patients, they have got NAFLD, and the incidence is more in patients with diabetes, obesity, overweight, and other metabolic disorders.
Dr. Sharma sir, you have rightly mentioned very importantly how obesity, type 2 diabetes, and metabolic syndrome is going to cause the NAFLD, and we have to be breaking the silence about it. And as we have just talked about, that normal liver goes to steatohepatitis and inflammation and fibrosis, leading to cirrhosis, and sometimes these patients go to HCC. So, Dr. Nijawan, what are the factors contributing to the rising prevalence of this disease? As has been just mentioned, you may kindly conclude.
You see, actually, nowadays the lifestyle are getting changed. Patients are on, the subjects are on very high caloric food intake. They don't exercise. They sit and do their job. Even the younger generation also doesn't do much exercises. The obesity is on the rise. Even in India, it has been shown that even the young generation are getting obese. And all this obesity and leads to insulin resistance, which is the key marker mechanism for causing NFLD. This lipidemia, of course, it comes in hand, especially in patients who are obese, especially in patients who are diabetics, type 2 diabetes, and certain other factors like CAD, hypertension, which leads to actually formation of a metabolic syndrome. Next slide. So lifestyle plays an important role. Even the diets nowadays are having a high sugar diet and high actually fat intake they have. And the Indian population among adolescents, they are becoming obese. And as has been told by Dr. Sharma, that obese patients, almost 90% have NFLD. So they go hand in hand. And there's an Asian paradox, which has been actually described from eastern coast of India by K. Das et al., where they have shown that more than 50% of NFLD patients had low BMI. So it is actually lean NASH, which is also there in India, with a lower waist-hip ratio, and insulin resistance is there. Next. As far as forecasting the prevalence of overweight and obesity in India in 2040, there was a nice paper which has come, and it has been predicted that the prevalence of overweight by 2040 as compared to 2010 will be double, and the prevalence of obesity will be triple. So the degree of overweight will be 3 times than the overweight. And it is more expected in people who are older, and even in the rural areas also, it has been predicted that the incidence will go up as compared to urban. As far as type 2 diabetes is concerned, there is a pandemic not only of NFLD, but there is also pandemic. India is a pandemic country for type 2 diabetes. Overall, global prevalence is around 4.7%, but if you take India, it is around 10%. And this map of India shows a comparison of rural as well as urban. And in South India, you can see that the prevalence of type 2 diabetes is equal in urban as well as rural areas. So actually, the type 2 diabetes is increasing even in the rural areas.
So, Dr. Nizaman sir, you have rightly pointed out that prevalence in India is also increasing, and you can see the waist-hip ratio is increasing. Our children are eating McDonald's and other junk food that is increasing very fast, and there is a generation XXS. In 50s, you see how our children used to look like. Now, how the childhood obesity is increasing as an epidemic, and it is worldwide a pandemic. And you can see that gradually the weight is going increase, and the man succumbs into the ground. So it is a very important thing. So we know that NFLD is closely associated with metabolic syndrome. Its individual component, insulin resistance, as has been rightly pointed out, Gauri, it plays a pivotal role in the development of NFLD. And now it is called as that this association led to the concept that NFLD is a hepatic manifestation of metabolic syndrome. So let us try to understand what this metabolic syndrome is. So Dr. Dadij, what are the metabolic disorders and what is the ATP3 criteria for diagnosis of what we call as metabolic syndrome? Dr. Dadij,
thank you. Yeah, thank you, sir. As you have rightly pointed out, the NASH or the NAFLD is the liver component of metabolic syndrome. And we all know primarily it consists of diabetes mellitus, dyslipidemia, obesity, hypertension, and you have the liver involvement also. So, but apart from these constellation of features which are associated with fatty liver, there are alternative causes of fatty liver also, which should be kept in the mind, like drugs and the maladjustment disorders, starvation, TPN, the post-bariatric surgery, and there could be a disorder of inborn error of lipid metabolism, which can cause fatty liver also. As far as the ATP3 criteria is concerned, there are total 5 features, 2 physical and the 3 lab parameters. The physical ones are waist circumference, which is lower in Indian. For male, it is 90. For females, it is 85 centimeter. And the blood pressure, which is beyond, if it is beyond 130 systolic or 85 diastolic, it is considered as abnormal. And you have serum triglyceride levels, fasting blood sugar levels, and the HDL levels. If there is a presence of any 3 out of 3 or more out of these 5 features, then the person is characterized or classified as having metabolic syndrome.
So it is very important that all of us who are clinicians should keep this ATP3 in front of our table. And as soon as the patient reaches us and we think that he has got fatty liver on ultrasound, we must assess all these points and try to find out if 3 out of these 5 features are present, then he is a likelihood candidate who is going to have a progressive disease. So Dr. Amit Mathur, as the metabolic factors are the drivers of development of NASH, what are the new thoughts while proposing new acronym to NASH, to metabolic dysregulation associated fatty liver disease, what is called as MAFLD or NASH or MFLD? That are the constituents of the MAFLD phenotypes.
So if we look at the spectrum of fatty liver disease, I'll take a few minutes to make a very important point very clear. We have the alcoholic predominant fatty liver disease and a metabolic dysfunction predominant fatty liver disease. In fact, these two were considered to be distinct entities, but now we find that there is a significant, may I have the previous slide. So that there is a significant overlap between these two entities. And in fact, there is, if you look at both of them are the most important cause of chronic liver injury in the entire world. We've talked about alcoholism, which is almost contributing to 5% of the mortality all over the world. And NAFLD is also almost 1/4 of the population might be affected. So this is very important to understand. What has been seen is that alcoholic predominant fatty liver disease, we look at this, because they are beyond a threshold of alcohol consumption, we label them as alcoholic predominant fatty liver disease, but majority of them are having a metabolic dysfunction. And only a minority of them are having no metabolic dysfunction. Similarly, if you look at the metabolic predominant fatty liver disease, what has been seen all over the West and in a lot of countries is that they are definitely consuming alcohol. The threshold of alcohol, again, that is very debatable because different societies give different threshold of alcohol. And what has been seen in a very large trial, which was conducted almost in about 190 countries, that there is no as such threshold where which the damage would take place. Even in 10 to 20 grams of alcohol consumption could contribute to altering the natural history to the clinical manifestations of metabolic predominant fatty liver disease. So there is a major group of metabolic predominant fatty liver disease where you will be having some amount of alcoholism, and only a small group of patients will be having a isolated metabolic predominant fatty liver disease. So obviously there is an intermingling and there is a significant overlap, and updated and more appropriate nomenclature and classification therefore is required to reflect the nuances of the disease etiology within the spectrum of fatty liver disease, because there is such significant overlap between the metabolic predominant and the alcoholic predominant fatty liver disease. May I have the next slide, please? So Why has it become important, as we have been talking about? Because there is a high risk of liver injury. There is a high prevalence. It has become a major impact on clinical and economic burden. And then there is a lack of treatment. In fact, it was way back in 1980 when Ludwig gave the first nomenclature of NAFLD. Now we need to revisit, we need to redefine the nomenclature as well as the diagnosis, how to diagnose NAFLD, because there is an absence of defined clinical criteria for a positive diagnosis. In fact, NAFLD is a sort of a diagnosis of exclusion. And now, since it has become so huge and so significant, we need to have a positive diagnosis of patients of NAFLD. That is, we need to find out what are the metabolic components, what are the alcoholic components which are responsible, and we need to identify the pathogenetic pathways. And the most important thing is, what we are seeing is there is a lot of heterogeneity of the population with NAFLD with respect to the primary driver and the coexisting disease modifier. As that I have told you, metabolic may be the primary driver, but obviously you have a coexisting alcoholism also taking place. So we need to find out which is the pathophysiology which is taking to the endpoint of steatosis, steatohepatitis, and this thing. So that has to be identified. Only then we'll be able to clearly define the natural history, compare the clinical trials, and we be able to define the medical treatment for this disease. May I have the next slide, please? So this has become very important. Next slide, please. So it's a heterogeneous phenotype. Now it is very well understood. Although hepatic steatosis is highly prevalent, only minority exhibit inflammatory injury, we all know. Individuals can oscillate, in fact, between steatosis and steatohepatitis. Liver-related complications, cirrhosis and cancer, they are more likely in those with steatohepatitis. But the progression is far from inevitable. That is, not all of them are going into cirrhosis and cancer. And in fact, at the other end, HCC can develop in a fatty liver in the absence of cirrhosis. This has also been seen. So the disease evolution can be modified by exogenous interventions like lifestyle changes, superimposed disease states like type 2 diabetes, inherited predisposition, and in fact, it can even spontaneously regress. And the other important thing is, we really don't know those children. In fact, there's a lot of incidence of NAFLD in children. What is the natural history of NAFLD in children as compared to vis-a-vis those who are acquiring it in adults? May I have the next slide, please? And next slide. So if we look at the heterogeneity, there have been a lot of factors which have been implicated. We have age, which is playing a role, sex, ethnicity, role of diet, role of alcohol, and obviously people are metabolically healthy or people are metabolically unhealthy. You have a microbiota, and above all, we cannot ignore the genetics and the epigenetics. So lot of heterogeneity, different disease subtypes, variable natural history, inter-individual variations, and variable response to therapy. So that is why we need to really redefine. In fact, what is we are looking into is a metabolic dysfunction associated fatty liver disease subphenotyping. Because what is going to happen is MAFLD in future would be subclassified based on new knowledge that might indicate the predominant pathophysiological pathway, which we need to know. That drives the development of a morphologically limited set of histologicals. That is, the endpoint is steatosis, ballooning, inflammation, and fibrosis. But what we need to identify is the pathophysiological pathway, which is leading to the development of the chronic liver disease.
Wonderfully told by Dr. Amit. Very well done. It's a new term which is coming forward, and we have to find out what is the basic. So probably in times to come, we'll have to classify our patients into patient 1, where the environmental factors are going to be predominant ones. The others would be where the metabolic syndrome is much more predominant. Genetic factors are also playing play their part. But in 1, there will be very little environmental factor, metabolic factor, but there is a genetic predisposition which is leading to development of NASH. So in times to come, this thing is going to change in times to come. And I think, so sorry for the interruption. I thought my voice has gone. So this is very important that we understand what is MAFLD. And I'll take 1 minute that we do not know exactly what is the amount of alcohol which is going to lead to the development of or progression of the NASH. So if a patient has got no alcohol intake and only fatty liver disease or NASH, his progression is going to be very, very slow. If one has got moderate alcohol intake is going to have a progression of disease. If you're taking 3 packs per day of 10 grams per day, then in the whole week, if he's taking 21 packs and females 14 packs, that is going to alter the whole scenario for development of this. So Dr. Dadish, which fat out of the visceral or peripheral fat is more harmful?
Sir, thanks for asking this question. The fat distribution in human body is either in the viscera or in the subcutaneous area. The viscera means around the abdominal viscera, not the subcutaneous fat present over the abdomen. So out of which the visceral fat is more harmful because it is strongly associated with obesity and related complications like diabetes, cardiovascular, and an FLD. And it acts as an endocrine and inflammatory organ, which leads to release of various cytokines and mediators, and that like TNF-alpha, IL-6, and the very less of adiponectin. And another very important thing is this visceral fat drains directly into the portal vein. So it delivers a lot of free fatty acids into the hepatocytes. And these free elevated load of free fatty acids into the hepatocyte leads to glucose intolerance and the generation of insulin resistance. And associated with lack of metabolism of these free fatty acids leads to development of fatty liver and is associated other complications. So the visceral fat is an endocrine organ, and it is active in the metabolism of fatty acids, and it is associated with metabolic syndrome and its other complications. Yes.
So very rightly told that in India, we have a pear-shaped body. That means lot of fat on the abdomen, lot of fat around the viscera, and we have very, very thin arms. We have very thin legs. So we are like a pear, and the whole belly is coming. So this is called as lean NASH. Our BMI may not be high, but we are going to have this type of visceral fat, which is very, very toxic. And he has rightly mentioned, Dr. Dadish, that this is itself an endocrine organ, which is damaging the most part in the liver. So what is the prevalence of NAFLD, Dr. Anurag, in each metabolic disorder?
Good evening, sir. Thank you so much. That's an interesting way of looking at the statistics. I mean, we all know and we've learned till now that most of NAFLD will have at least one, and 1/3 of NAFLD will have almost all features of metabolic syndrome, to the extent that ASLD goes on to say that if you have several metabolic diseases, it becomes the most potent indicator, predictor of an adverse outcome. But what is interesting is what you just asked, that if you take the reverse, what is the incidence of each metabolic component? So obesity, of course, is the most common risk factor. The entire spectrum, whether it be just overweight, whether it is obesity, or whether it is the severe form of obesity, which is morbid obesity, they're all associated with NAFLD. And more than 95% with severe obesity undergoing bariatric surgery have NAFLD. So this forms was the most important component. If you take diabetes, obviously we're talking of type 2 diabetes, then the literature says that 1/3 to 2/3 of diabetics have NAFLD. And what is interesting here is that both can develop simultaneously. And so this brings in a very important fact of insulin resistance being the key to the development of both. Dyslipidemics, most dyslipidemics, more than 50% attending a lipid clinic have NAFLD. And various reports have ranged it from 27 to 92% of dyslipidemics having NAFLD. So basically what we derive at by treating these, by studying these statistics in the reverse direction is that this association between FALD and the components of metabolic syndrome are bidirectional. So NAFLD have a lot of metabolic syndrome components, and individually the metabolic syndrome components have a lot of NAFLD. Thank you, sir.
So it's a great information which we have received that you have more metabolic syndrome in a obese person and type 2 diabetes person. So there will be that if you have more MATs, you have more of the liver disease. More of MATs, you have one of the things which is happening. And dissecting these patients into the type 2 diabetes and obesity and the prevalence of NASH is very, very important. So ASLD has suggested a notable change in the guidance that it's a stronger emphasis on assessment of metabolic risk factors. And we are going to do it in a greater detail today. In patients with incidental finding of hepatic steatosis, with or without normal liver chemistry, but lacking liver-related symptoms, we know that this is very, very important. So, Dr. Rupesh, do you think that early identification of individuals' components of metabolic syndrome are critical in preventing both cardiovascular and liver-related mortality? Dr. Rupesh, please.
Thank you, sir. I think it is very important. We have already discussed component of metabolic syndrome by Dr. Dadich also, and we have know that all these factors from diabetes, hypertension, dyslipidemia, waist circumference, and individual factor is important in the mortality. Even whether they're, and we have already seen the ranges of value. Next slide, please. We know that NAFLD is a hepatic manifestation of metabolic syndrome. And both are interrelated, each and interrelated. And in fact, we know that in metabolically abnormal NAFLD, the cardiac mortality is more than the liver mortality. In this group, the liver disease mortality is less and the cardiac related mortality is much higher. This was a large study which was done 2 years back, which shows that the mortality is 30 times higher in a patient with NAFLD and metabolic syndrome. This was a study after 18 years follow-up, and they have showed that mortality NAFLD with metabolic syndrome is very high. This is not because of liver disease, this is also with cardiac disease also. And with graded increase in the mortality with each component of metabolic syndrome, the mortality increase. And in fact, we have seen that with increasing age and with one more component of metabolic syndrome, increased liver-related mortality. Diabetes, hyperlipidemia is also associated with progression of liver disease. The waist circumference, if we have waist circumference, which is more than 5 centimeters, this also increases the mortality of coronary disease. And this central obesity is more dangerous than peripheral obesity. Lastly, dyslipidemia is a common risk factor for both NAFLD and cardiovascular mortality. More important is decreasing the lipid lowering agent reduce cardiovascular event in general population, but may not do it in a patient with NAFLD. Statins are more important in patients with NAFLD and dyslipidemia, and maybe omega-3 fatty acid is more important in hypertriglyceridemia. Thank you, sir.
Rupesh, you have very importantly brought this important point that overall mortality is high, but more importantly, liver-related mortality with NAFLD is low and the cardiac one is high. So we should try to find that if a patient comes to us with NAFLD, that should we screen all patients of NAFLD in the general population? Who should be screened in the special risk population like obese and diabetes? Different societies recommend differently. What is your opinion, Dr. Mukesh Kalla?
Yeah, sir, thank you so much for the opportunity. And when we go through the literature, we understand that this is a disease with great prevalence and a great number of patients are affected by non-alcoholic fatty liver disease. So it is practically not possible to screen each and everybody because the cost burden will be very high. So the whole scientific society is behind to assess who should undergo and who should not. So all societies recommend against general screening for NAFLD in patients with obesity. But yes, with diabetes and obesity should be screened for NAFLD. Again, but if there is a difference of opinion between Americans against the opinion of Europeans and Asian societies, wherein Americans probably do not recommend general screening, whereas Europeans and Asia Pacific study for liver disease, ASLD, suggests that there should be a screening for high-risk patients who are suffering from diabetes, obesity, and those who have, other related risk factors for developing NAFLD, which is a subsector of NAFLD.
So how should we prevent the menace of this pandemic called NAFLD NASH? Early recognition and intervention are key to improving clinical outcomes and reducing economic and health care burden of NAFLD. Despite this, widespread awareness of NAFLD in primary care setting is lacking. So, Dr. Bhupesh Kulkarni, what steps should be taken to improve early diagnosis and awareness in the primary care setting? Dr. Rupesh,
Basically,
please.
this disease is basically for a primary care physician because the prevalence is so high all over the world in country. And these are very small. We have already discussed metabolic syndrome. We have discussed features, 5 features we have discussed. And we know that obesity, diabetes, hypertension, hypertriglyceridemia, these all factors are being governed by primary care physician. And next, please. The most problem is this, that majority of the time patients goes to without any problem, because patients are not going for NAFLD. Majority of the patient with NAFLD have no symptom, or maybe very, very vaguely they have few symptoms. So majority time they are going to primary care physician. The problem is that majority they underestimate the prevalence, which we have seen in a study. This is from US basically. 33% have underestimation. 69 don't identify as an important clinical finding. This is the awareness. This is a study not from India. This is a study from US. And this is very recent study also. And 53% are uncomfortable with the management of NAFLD. So urgent need is there to educate primary physician regarding the NAFLD, epidemiology, and workup. Next. Routine, already Dr. Kalla has discussed that routine screening usually is not advised in certain US. They don't advise even for the high risk. The screening for NAFLD is not required. But whenever there is a high risk of suspicion of NAFLD or NASH, especially in patient with diabetes or dyslipidemia, we should do some screening. And on the basis of that, next slide, please.
Sorry.
Sorry.
We are going to discuss the whole protocol in next few lines after this.
Okay. I'm stopping here. So I think the basic thing is that the awareness should be increased at the level of primary care physician. They should try to understand, because these are very common situation, and then they try to manage, understand, and the prevention at this stage will be very important for progression of these both cardiac as well as for liver disease.
So you have very rightly pointed out the importance of spreading the awareness among ourselves as clinicians, and try to see that initially I also used to think that this fatty liver disease diagnosis by our radiologist colleagues is a waste paper diagnosis. But then later on, I realized that I should have been more aggressive in these group of patients in identifying as to how we should go about and investigate these patients. So let me just go forward to a case. As I just discussed earlier, that this IT firm executive had chief complaints of fatigue and right upper quadrant pain. His other parameters were there. He had just firm liver, and there was black pigmentation in the armpit and the nape of the neck. So what initial assessment should be done in an incidentally detected person with fatty liver disease grade 4 on ultrasound? So Dr. Kalla sir, would you like to enlighten us as to how should we go about?
Yes, sir. The fatty liver disease will encompass a lot of other diagnoses as well, just not a non-alcoholic steatohepatitis. Like if you go into the history of the social drinking, Americans would probably permit a lot higher amount of alcohol to be considered as a social drinking, whereas the Europeans and Asian guidelines permit lower amount of alcohol to be considered as non-alcoholic steatohepatitis. But yes, if you have a patient who has diabetes, obesity, hypothyroidism, polycystic ovarian disease, sleep apnea syndrome, etc., these things, we have to get into great detail of the history of these patients and look for the cause of steatosis. What is the cause of steatosis in these patients? So liver function test and CBC becomes a very important part, because we should get a liver function test for each and every patient. If there is a transaminitis, then you have indirect markers of suggestion, which would probably say that patient probably has steatosis and hepatitis. So we understand that there are two components of this disease. Non-alcoholic, we have discussed the limit of alcohol. Steatohepatitis. So steatosis would probably be reflected by other parameters of markers, APRI, FAB4, etc. And transient elastography will give us a CAP score, whereas the hepatitis part will be assessed by steatohepatitis. Now, if you see this transaminitis, then you better rule out acute viral markers should be done. Autoimmune hepatitis, hemochromatosis, and other causes for elevated enzymes should be worked up before we label these patients to be suffering from NASH. And yes, now we have a good number of other non-invasive validated investigations available, which are very subjective, proven across many scientific studies to be, reasonably with the negative value and the positive specific values with the fibrosis 4 index. You can just have a calculator, which is easy to do. Elastography is now commonly available, FibroTouch, FibroScan. Then you have SGOT upon platelet ratio index, which also suggests. So liver biopsies, of course, we need to talk much in detail about this. Thanks. Yeah, Rai sir?
Yes, sir. 1 second.
Yes.
So, Dr. Nijawan, liver biopsy, as has been told lastly by Dr. Mukesh, that is the gold standard for differentiating simple steatosis for NASH. Can any other non-invasive test differentiate them? What are the non-invasive predictors of NASH in patients with NAFLD? When should we obtain liver biopsy? Would you like to enlighten us?
Yeah, actually, there are certain non-invasive tests are available to differentiate steatosis versus NASH, but there are no currently available gold standards to actually non-invasive tests to actually differentiate the two. So there becomes the role of liver biopsy. But looking to the pandemic of non-alcoholic fatty liver disease going to NASH, how many liver biopsies can be done? You have to select out the patients and then you have to go ahead and do it. So there are actually certain non-invasive tests with us. FibroScan is the commonest imaging test which we have. Then newer ultrasound machines, the point shear wave elastography and the newer ones like 2D shear wave elastography. These are ultrasound-based tests to say for the presence of steatosis as well as stiffness, that is fibrosis. Then we have got MR elastography, which actually quantitates the amount of fat in the liver, and at the same time it gives a larger view of the amount of fat. Next slide. So as far as FibroScan is concerned, actually it's basically a vibration controlled transient elastography, and it very well correlates with the stiffness value correlates with the fibrosis, and CAP value actually correlates with the steatosis. It's a non-invasive method, and it is 100 times has a bigger volume than a liver biopsy. So a larger chunk of the liver is assessed by transient elastography. It is accurate and reliable and has been shown to assess the liver fibrosis steatosis in patients with NAFLD. So it's basically a transducer actually, which is applied to the percutaneously, and it has a diagnostic accuracy for a higher rate of false positive than false negative, and higher negative predictive value than the positive predictive value. So a higher stiffness goes in favor of predicting that patient has cirrhosis of the liver. As far as comparison of MR with the US elastography is concerned, US elastography, it is cheaper, it is available in the ultrasound machine, widely available, and at the same time you can actually you can do HCC screening. But the point is, like, you cannot quantitate the fat with ultrasound elastography, and in certain conditions like in the presence of morbid obesity, ascites is difficult to do, and it has a limited sampling. It's more than that of a biopsy, but if you compare it with MRI, which is a large screening sample, the whole of the liver is screened and it quantitates fat. At the same time, in MR, you can see SCC. And but the point is, it is not easily available in all MR machines. It has got a special software, so it becomes expensive. And patients with a iron metabolic problem in the liver, it becomes a problem to do MR. And it is still not validated test for actually quantification of the fat. Next slide. And as far as the liver biopsy is concerned, it should not be performed in each and every patient with NFLD. And if there's an uncertainty of the diagnosis, as has been pointed out by Dr. Dadish, there are series of actually mimics of NFLD, other causes which lead to fat in the liver. So if there's a differential diagnosis, there's a coexisting other liver disease, then you have to do a liver biopsy, or you suspect advanced liver fibrosis on other non-invasive tests, then you have to do a liver biopsy. And especially in drug trials, a lot of new drugs are being tried. So it becomes a primary endpoint which have to be assessed by doing a liver biopsy. In fact, we have a pre-trial liver biopsy which has to be compared with a post-trial liver biopsy. Next slide. So any patient with NFLD, NFS score should be there, which has been pointed out very well by Kalla. And you do a transient elastography. So if the NFS score is less and the stiffness is less, so there's no advanced fibrosis, you have to follow these patients. If there's a discordance between the NFS score and transient elastography, you have to go ahead and do a liver biopsy and manage accordingly whatever you get. And if there is a high score on NFS and LSM is high, likely that there is an advanced cirrhosis, a liver biopsy should be done to actually grade the amount of fibrosis and further treatment for NASH.
So I think fibrosis is the main driver of the disease progression for cardiovascular and liver-related morbidity and mortality. In fact, is there any connection between the liver and heart? Let us just analyze in 2 slides as to what is happening. So if you have intestinal gut microbiota, you have adipose tissue and sedentary habit with genetic predisposition, there is a lot of metabolic inflammation which is taking place, and type 2 diabetes is precipitated, cardiovascular disease is occurring, or neurocognition dysfunction is occurring. So here you have a metabolically disqualified person who has got hypercaloric diet, sedentary habit. Then you have the pancreas which is producing hyperglycemia. You have a lot of inflammation which is taking place, and these inflammasomes, they go and do a process of atherosclerosis by increasing endothelial dysfunction, vascular inflammation, plaque. So now the whole driver is here in the liver. So we have something common which is happening in both liver and the inflammasomes which are going to circulation, which are leading to atherosclerosis. And there is something which is common, that you have all metabolic factors for liver disease, and the same are true in the cardiac lipotoxicity. So there is a NFLD and cardiac toxicity, and you can assess by the intimal thickness of the carotid artery, that you can do then decide whether this patient of NFLD is going to have high incidence of cardiovascular morbidity and mortality. And a study has shown that out of the NFLD, if you have NFLD, there is a 5% increased risk of cardiovascular disease as compared to those who did not have NAFLD. So it is important that liver fibrosis is making a very good impact, and it is increasing the morbidity. So now the end point of all disease progression is seen, that if you have stage 1 or stage 4 disease, you have age and diabetes and current smoking, you have high index of morbidity and mortality, both for liver as well as for cardiac events. And the death rate also is very high in those patients who have NASH, and in non-NASH, you have with fibrosis, there is increased mortality. So fibrosis has been found to be very, very important. And we'll be discussing that if you have high NASH score and less of fibrosis, the mortality is low. If you have more fibrosis, there is more mortality. So it has been now thought that new endpoint is fibrosis is the driver of progression. Histological NASH may not be that important. So it is important that we should assess the fibrosis. Dr. Anurag, liver biopsy is the gold standard, but not feasible in all patients. How can we assess non-invasively advanced fibrosis in patients with NAFLD?
Sir, I hope everyone can hear me.
Yes,
I think
we are able to.
Some very, very important part of the discussion today. This busy slide is a fallout of what we are facing. And when I say that, here is a disease almost of epidemic proportions. 30% of the general population has got fatty liver. These consequences of having a fatty liver and metabolic syndrome are grave to the extent that the mortality increases. And the gold standard of diagnosis is liver biopsy. So obviously, Dr. Nijaman has very rightly said that you can't be biopsying, such a huge population. So whenever you face such a situation, other tests which can reliably predict fibrosis or other features of histology will obviously bloom. And that is why this very busy slide. So I will not go through all of this. Let's just focus on the last line of the slide. That there are so many, but no method easily performed in daily clinical practice and with a high predictive value for differentiation between the grades of fibrosis has been identified till date. So despite the fact that you've got so many, I will just focus on the first two. And the first two are NAFS, which is the NAFLD fibrosis score, and FIB-4. These two, what is important for these two, that they've been recommended, highly recommended by most of the societies, ASLD, even the European Association recommends it, even the Italian Association recommends it. And both these tests carry a very, very high negative predictive value. So if the value of these tests is low, you're reasonably certain you're not dealing with advanced fibrosis. And these tests are very simple to perform. You have some very, very basic clinical features like for NFS. Can I have the previous slide, sir? So like for NFS, age, BMI, albumin, the sugar status, platelet count, and AST/ALT, something that you do in almost every patient. These can be fed. Everyone has today smartphones, net-driven phones, and just feed this data on the site and you get a score. And this score is very important clinically. So a low score will exclude advanced fibrosis and a high score will identify, in most of the cases, advanced fibrosis. Of course, there's a very big gray zone in between and we need better sensitive tests for those. Can I come to the next slide, please? On similar grounds, there is this score which is easier to do, which is called FIB-4. Here you need only platelet count, the age, AST/ALT, feed it into your cell phone, you get a result, and again, low score, unlikely fibrosis, high score, advanced fibrosis. And these two, that is NFS and FIB, they have been shown to be better than the other ratios that you can use clinically. And in patients with advanced fibrosis, they're as good as MR in predicting the presence of fibrosis. So this is so far the value of these tests. The next slide, please. Sorry. So that's all. Thank you, sir. Sir, Dr. Rai, sir.
Sir, mute ho gaye.
Sorry. Very important points we have brought out, that these are common things which are available with us. You can calculate every day. We have to be smart clinicians now with a smartphone. We calculate these things and decide that this patient has got high fibrosis or low fibrosis or no fibrosis. If it is no fibrosis, you can just relax for some time and see that patient, he goes for lifestyle modifications And if it is high fibrosis, you try to treat them. So it is very important. We should be smart, using smart clinicians, smartphones. So there is one more test which has recently come forward, that is called as FAST test. So Dr. Amit Mathur, non-invasive assessment of fibrosis by FAST score in the diagnosis of fibrosis or plus minus necroinflammation, how good it is?
So like we were talking about smartness, this is a very interesting study which has come up in Lancet Gastroenterology, where they have taken this FAST score, and it is in fact done a multicentric trial where they have looked into the FAST score, whether it is a good non-invasive method for identifying patients who are at a greater risk of progression to cirrhosis and who will be candidates for clinical trials and emerging new pharmacotherapies. And they help, in fact, aim to develop a score to identify patients with NASH, elevated NAFLD activity score, and advanced fibrosis. And they, in fact, took almost 300 patients. It's a big number. And obviously published in Lancet, where they looked into the fibroscans, where they looked at the liver stiffness measurement and also the CAP measurement, which is easily measured by a fibroscan, and also the liver functions, which are very easy to measure. So when they used these parameters and looked into the almost more than 300 patients, they could find out a new predictive model which combined LSM CAP, which were measured by fibroscan, and AST. And they were found that there was a good high positive predictive value, and in these patients, when they calculated all of these patients were previously subjected to liver biopsy, and it was a reasonably very good trial, and they could reasonably well predict with a good positive predictive value the patients while combining LSM, CAP, and AST. And this was provided, next slide please, next slide please, an efficient way to non-invasively identify patients at a risk of progressive NASH for clinical trials or treatments. And it would possibly in future reduce the unnecessary liver biopsy in patients unlikely to have significant disease. Simple parameters wherever you have an available fibroscan, and combining it with AST was found to be the most sensitive among all these parameters. Combining the fibroscan and AST, which was known as a FAST score, they could easily come up predicting those patients who are more likely to develop chronic liver disease. Recent article in that.
Wonderfully, Amit, you have brought out a very important thing, and I feel that combining AST-ALT ratio and the fat in the liver and the fibrosis, the scores, now we can at most think that probably we are at a point where liver necroinflammation and fibrosis both can be assessed very easily in patients with very simple ones, and then time is not far away that we'll be avoiding liver biopsies in all our patients. Dr. Dadij, how can we non-invasively assess severity of fibrosis by imaging techniques? I'll request every of my colleague panelists to, because we have exceeding the time, and I think we should go fast in going to the treatment one. So we'll be very fast now and do the...
Yes, sir. Actually, sir, the most of this talk has been, I think, given by Dr. Nijavan. We know as far as the imaging is concerned, the fibrosis can be diagnosed by the help of transient elastography or VCTE and the Sear wave elastography, which is based on the ultrasound. The vibration controlled transient elastography tells you the value which ranges from the lower one to highest one, which is 75. And it tells you about the elasticity of the liver. Rather, both of them will tell you about the elasticity of the liver. And depending upon the value, we can divide the person as having early or no fibrosis and as well as the advanced fibrosis. And the certain limitations I want to highlight, I think Dr. Nijavan didn't do it. The fibroscan is of limited value whenever a person has got high BMI or a ascites or a free fluid in the abdomen. Whenever he has a jaundice due to other causes like cholestasis or acute liver injury, or if they have a congested liver, then it is of less value. The same is true for these two other techniques based on the ultrasound. since fibroscan is the most validated technique all over the world. So this is the preferred over the shear wave elastography, which can be done with the conventional ultrasound machine. And both of them can be used for deciding the stiffness of the liver and accordingly the fibrosis of the liver. Thank you, sir.
So, Dr. Sharma Sahab, as we talked about that fat can be estimated very well with MR, can we also estimate the fibrosis with MR elastography?
Yes. Yes. MR elastography is one of the best way of demonstrating the fibrosis, because there are certain situations where the other methods which are used for estimation of fibrosis may be misleading, as told by Dr. Dadish, Dr. Nijavan. So this is a very good way of demonstrating the fibrosis. And even in the presence of obesity, ascites, it can be accurate as compared to the other tests. The only problem with the MR is that it is not frequently available and it is more costly. Three types of the MR imaging, that is MRS, magnetic resonance spectroscopy, MR PDFF, that is proton density fat fraction, and recently spin ecoplanar. They all can very well give a value which is equivalent to liver biopsy for assessing the liver fibrosis. And the spin ecoplanar can overcome the problem caused by the iron. Previously, iron used to give false interpretation, but now with this, we can know degree of fibrosis even in the presence of the iron. So the only disadvantage is it's very costly and not available everywhere.
So Dr. Sharma sir, very importantly told that time is not far away when most of our MR machines will also have this thing, and we'll be able to get some smallest cut of the liver and assess as to how much is the fibrosis very accurately in presence of ascites and other things. So if you approach a patient with non-alcoholic fatty liver disease, whether it is low suspicion or intermediate or high suspicion, it all depends on whether we have one feature of METs, no family history of cirrhosis, and FIB4 is less than 1.3 or NFS is less than 1.45 and AST is less than 20. We treat as low risk, monitor the patient for the new risk factors which are there with him, try to give him lifestyle modification. If you have intermediate or high suspicion, that is more than two of the following, that is obesity, BMI more than 30, more than 25 kilograms in Asians, age more than 50, family history of cirrhosis, and any of the following, two features of METs, persistent AST about 20, FIB4 more than 1.3, NFS more than 1.44, assessed for the liver stiffness, as has been just pointed out by Dr. Dadij. So assess the liver stiffness. If it is less than 6.5 kilopascals, you treat as intermediate or low risk patient, consider reassessment after 6 to 12 months. If you go for the transient elastography showing more than 6.6 to 8.5 kilopascals, inconclusive reading, additional LSM can be done again by MR elastography. And if you find that MR is low, MR is high, consider for the liver biopsy, that means fibrosis is there. So intermediate patients need to do this thing. And another, if you have more than 8.5 features of cirrhosis, treat as high risk NASH cirrhosis and treat these patients. So it's a very important diagram to assess as to how whatever investigations we have talked about is going to give us a guide pathway as to how to approach. So how should we approach a patient with NAFLD and NASH? Should all patients be treated? Doctor, it is very important to understand that management will be lifestyle modification, liver-directed therapy, manage complications of cirrhosis, target components of metabolic syndrome. This is very important. Lifestyle modification and targeting the components of metabolic syndrome in the management of NAFLD is going to be very important. So NAFLD is a lifestyle disease and various components are there. We'll discuss as to how we can change our lifestyle. Dr. Nijavan Sahab, what modifications in diet would you help in the management of NAFLD?
Yeah, actually, you see, if you mobilize fat, then it not only actually decreases the liver fat, but also actually decreases the cardiovascular risk. So the same diet modification not only helps the liver, but also helps the heart. And it is around 750 to 1000 kilocalorie decrease in the total amount of calories, may it be fat, carbohydrate, or protein. You actually decrease the insulin resistance, which is the key in the mechanism of development of NASH. Then various sugars, uh, then we have candies. All these actually different type of carbohydrates, they are actually dangerous. Then saturated fats, like in lamb or pork, non-vegetarian, butter, coconut oil, full fat dairy products, all these have a high degree of dangerous fat to be consumed. Next slide. Can we go to the next slide? Yeah. And it has been shown that exercise along with dietary restriction is important. So it's not like you only restrict diet and don't do exercise. If you combine the two, then actually there is improvement in the liver histology, that is decreasing the fat, decreasing the inflammation, ballooning, and fibrosis. And so it's not only one, it is a combination factor. And crash diets are to be avoided because it has got a deleterious effect. So it has to be gradual reduction in the diet rather than crash diet reduction. And it has, up till now, it has not been shown that which type of macronutrient in the studies that should be decreased to decrease the amount of liver inflammation and fibrosis. Next. You see, Mediterranean diet is very helpful in NASH. It is actually, southern part of Europe, northern part of Africa, and the western part of Asia, around the Mediterranean Sea. Actually, that type of diet can be actually, if you see the Indian diet, you can make it. The protein content should be 25%. They eat fish and meat. We can eat legumes. We can have dal. And the cereal should be only 25%. The 50% chunk of your diet should be actually vegetables and fruits. So that is very important. And they should be cooked in, they cook in the olive oil. So olive oil should be more frequently used rather than we are using ghee. And of course, a glass of wine with each diet, which as Indians, we don't do it, but the Mediterranean countries do. Next slide. All these, if you go to the various societies, the main reduction is the amount of kilocalories deficit. So all recommend the reduction of 500 to 1000 kilocalorie reduction combined with aerobic and resistant exercises. All societies recommend it. Though there is no suggestion of any specific type of diet to be restricted, but it has to be reduction of the fat diet, increase in the protein diet, and a moderate consumption of the carbohydrate diet. Yeah, that's it.
We can't hear you.
Thank you, Dr. Nizam, for bringing out very, very important points. Let me just summarize in one line. 30% reduction in the all components of the diet is going to be very, very useful. So reduce all things, and calories should be reduced by 500 to 1000 kilocalories. And another important thing is which type of oil you use, that goes on changing every time. So all things which are containing less of MUFAs should be increased in MUFAs should be used, and that is olive oil has been found to be very useful in the Mediterranean diet. And we can also try, though it's a very costly one, so we should use it as and when our pocket allows, but we should use this type of thing. And exercise, as has been rightly pointed out, is very, very important in us bringing up. So Dr. Sharma sir, what type of exercise and duration will help in managing the patient of NAFLD? Dr. Nizaman has rightly pointed out few of things. what are the overall added advantage of exercise on the other systems of the body? Dr. Sharma?
Unmute.
Yes, yes. The intensity, type of exercise, volume of exercise is still debated. But majority of the patients with NAFLD, they are engaged in minimal physical activity. So, and this increases metabolic syndrome and NAFLD. So, exercise is very important part of their management. Next slide. So, but the optimum duration intensity remains indeterminate. Patients who are physically active, that is more than 150 minutes of exercise per week, or at least that will cause decrease in AST level independent of the weight loss. Even if there is a no weight loss, the AST LT will decrease. Vigorous exercise for more than 250 minutes per week improves the hepatic steatosis, necroinflammation, and fibrosis. So next. So if good health and no physical limitation, 50% aerobic and 50% resistant exercises will be good. So these are the various patterns which have been suggested to decrease the effect of the, to increase the effect of exercise on the various metabolic activities and the NAFLD. Thank you.
So we have just talked that alone exercise is not good, alone diet is not good. So combination of both is going to give a very good results. And another good thing which has been brought forward is that there is a term called as fit fat. So relative benefit of exercise without weight loss also, it has been seen in one of the studies that it increases the insulin signaling, calorie disposal through the interaction with the skeletal muscle substrate utilization, PPAR signaling and mitochondrial metabolism, leading to improvement in the insulin resistance and liver fat at imaging has been found. So you have to do exercise. Even if you don't lose weight, you are going to have a fit fat, which is very good for you. Dr. Govil, how weight loss can help in managing patients of NAFLD? How much weight loss affects each component of NASH? Can diet alone or exercise alone can reduce weight, or do we need to do both activities for weight loss?
This also, I think, again, is a very, very important aspect of NAFLD, because weight loss eventually holds the position of keystone. It holds the position of keystone element in improving histology. And end result of sustained weight loss is obviously liver fat mobilization, which is what we want. The modalities could be, of course, diet alone, exercise alone, and a combination. So we've had, of course, enough views on diet alone and exercise alone. Combination is obviously the best. So I will run over my slides because I don't want to duplicate. May I have the next slide, sir? So here is a beautiful representation of this triangle, that if you, whether it is diet or exercise or a combination, if you lose about 3% weight, the steatosis decreases. You lose and maintain 5% loss, the ballooning and inflammation also goes down. You lose 7% of weight, and there is a resolution of almost all parameters of NASH. And if you lose more than 10% weight and maintain this loss, then even the fibrosis regresses. And this is why, whichever way that you do it, eventually weight loss holds the keystone position in treatment of NASH today. The next slide, please. So we've had a discussion on diet alone. What is important to remember is that if you go very low on calories, please remember it can have deleterious effects. The next slide, please. And if you have physical activity alone, again, most of it has been said. A word of caution here is that NAFLD can have high comorbidities. So please, before you advise vigorous exercise, rule out comorbidities in your patients. And therefore, diet alone and physical activity alone do not hold the way to go. But maybe the next slide, please. Combination is the logical outcome. And you have enough studies which show that if you use a combination and then decrease weight, everything including fibrosis and NASH goes down. The next slide, please. So without repeating, I will just bring out two important AASLD guidelines 2018. A combination of a hypocaloric diet and a moderate intensity exercise is likely to provide the best likelihood of sustaining weight loss over time. A weight loss of at least 3 to 5% of body weight appears necessary to improve steatosis, but a greater weight loss up to 10% is needed to improve the majority of the histopathological features of NASH, including fibrosis. Thank you, sir. Dr. Rai, sir.
Sorry, you have brought out very important things that diet alone is not good, exercise alone is not good. So we have to do both of them. And still, a lot of people will not stick to it. Even if we tell them, they will not do it. So they will ask, Doctor Sahab, ek goli likh do, zyada acha rahega. And I know that not many things are available for the treatment today, but not many things are on the pipeline, and we'll discuss few of them. Dr. Amit, what pharmacological treatment aims in all these patients of NAFLD? Should we treat all or with what?
So, the primary aim of treatment, as we all know, is to prevent or reverse NASH, and obviously to prevent the progression to cirrhosis and its sequelae. But more importantly, as we have already discussed, there is emerging evidence which suggests that NASH is associated with the incidental increase in the cardiovascular disease, which is an independent of traditional risk factors. May I have the next slide, please? So the pharmacological treatment is aimed primarily at improving the liver disease, and it should generally be limited to those with biopsy-proven NASH and fibrosis. May I have the next slide, please? So, but there has been a difference of opinion among the various societies. We have been looking at the guidelines, but what the European guidelines, they say that it should be reserved for progressive NASH, that is bridging fibrosis and cirrhosis, early stage NASH at high risk for disease progression. So we need to identify this group of patients. So those with age more than 50 years, metabolic syndrome, diabetes, raised ALT, or an active NASH with a high necroinflammatory activities. The other societies like the American Society, may I have the previous slide, and the Asian Pacific recommend only for patients with NASH and fibrosis. The Italians, they look at the advanced liver fibrosis, and also they said the AISF says that suggests for patients who are at high risk for disease progression. So we have still not very clear, but yes, this has to be applied only to a limited group of patients of NASH.
Look into it, what are useful and beneficial for our patients. So, Dr. Pokhana, what are the insulin sensitizer? We talked that insulin resistance is the key thing which is playing a major role. So, what are these insulin sensitizer in treatment of NASH?
Yes, sir. We know that it is a very common problem. 20 to 30%, we know that 30% may develop NASH in all patients with NAFLD. Insulin resistance is very high, 45% in our country. The sensitizers are, one is biguanides, which is metformin, which nowadays not been used, not been approved. It has not been used for in the patient with NAFLD or NASH. Thiazolidines, which are two drugs, pioglitazone and rosiglitazone, out of which pioglitazone is being used. Rosiglitazone is not being used nowadays, not being used because it is associated with significant cardiac complications. And lastly, GLP-R agonist. Next slide, please. We know that this is PPAR receptor gamma, which are improving the insulin sensitivity at the level of adipose tissue and liver and muscle. The mechanism is not completely understood, and it increases the adenopectin levels, and this increases insulin resistance and decreases hepatic fat content. Next slide. The problem with this drug was is associated with certain complications like pioglitazone, which is associated with increased weight gain. And in the long duration, because these drugs are being used for a long duration, not for a short duration, and it is being for up to 2 years, which is associated with increased weight gain, associated with bone loss, and associated with increased incidence of bladder malignancy. And that is the reason that rosiglitazone was not being used, not been approved now, because it is associated with increased cardiac events are there. Next. This is another drug which is called as glucagon-like peptide agonist, which is secreted by L cell of the intestine, which regulates blood glucose via stimulation of glucose-independent insulin release. It is not a direct insulin sensitizer, but out of which there are two drugs, which is axinetide and second is liraglutide, which are being used. And this drug, which is used in large number of the patient, which associated with decreased aminotransferase as improvement in histology, but this drug has not been approved till date. Finally, I just want to say one more thing regarding pioglitazone. Next slide, please. There are various studies which have been shown, which also shows that they are associated with improvement in the liver enzyme, also the improvement in the steatosis, inflammation, and few studies they have shown improvement in the fibrosis. So this drug is being used sometimes, especially in the patient with diabetes and without diabetes. It's only in the NASH patients. Thank you very much.
So, Dr. Mukesh, we often talk that it is antioxidants have been found to be useful. And how is the role of vitamin E in the treatment of NASH?
Yeah, thank you, sir. So we often believe that any supplements like vitamin E would probably just be a placebo effect. But as of now, for the scientific data available for treatment of NASH, vitamin E probably holds the only scientifically proven role in helping to treat NASH. So many wonder drugs are now coming in with more trials, and we will talk about them subsequently. But as of now, if we talk about literature, vitamin E is one thing. You know, the idea came up from the point that alpha tocopherol levels were low in NASH patients, and they found that when you use vitamin E, then it causes this is a free radical scavenger, and it hits hard to, decrease steatohepatitis. So, but the important thing is that you will need to give this medicine for a long duration of time. So you have to have a cost-effective approach to vitamin E's use. We know that when you use vitamin E for a long duration of time, you invite risk for hemorrhagic strokes and prostate cancers. Therefore, keeping this in mind that you should only use this medicine if you have a biopsy-proven NASH, one thing, and in non-diabetic patients. And as of now, not recommended in cirrhosis. I have written this comment here, but now we have more trials dropping in, which they say that the transplant-free time for decompensated cirrhosis on vitamin E is significantly improved, which would probably mean that vitamin E will have role in cirrhotics as well. Next slide, please. So, just to, put forward the point that how good is this medicine, there was a PREVENT trial and there was another tonic trial in children also, where they were non-diabetic patients who were given vitamin E for a long duration of time. And they found that there was a significant P interval, like 42% patients had benefit versus 19% placebo. So, it is conclusively proven that vitamin E helps in NASH patients. Next slide, sir. So I will not go into details of the, statistics of this particular trial. The benefit was that those with or without diabetes on vitamin E users, at just a 10-year cumulative probability of SCC, non-hepatic cancers were low, and vascular events were not different between vitamin E users and controls. So therefore, to say that vitamin E as of now is one medicine which should be utilized in patients, but yes, with caution, and preferably in patients who have biopsy-proven NASH. Thank you, sir.
Thank you, Doctor. So, Dr. Dadij, there is a new drug on the horizon, which is saraglitazole, which is a Indian drug which has been very thoroughly studied. And I would like to have your opinion and what this drug is and how does this drug saraglitazole acts.
Yes, sir. Saraglitazole belongs to a drug which is a dual PPAR agonist. And the PPAR, we know they are the nucleic acid receptors, nuclear receptors, which when stimulated leads to changes in various metabolic activities. This compound, saraglitazole, developed by our own company, uh, stimulates both alpha as well as gamma PPAR receptor. Alpha receptor, as we know, this is basically related with the fatty acid catabolism and the inflammation and detoxification. So this is the major factor which is there in patient with NASH. Next slide, please. The saraglitazole is different because it has got the next slide. Keep on clicking. Sir. Saraglitazole is a different because it is a predominantly having alpha PPAR agonist activity and the less of gamma activity. So it has got a predominant role in fat catabolism. Next slide, please. So it acts at all three levels of NAFLD spectrum, which is inflammation. The initial is fat deposition, which is steatosis. Second is inflammation. And third is fibrosis. It reverses both steatosis as well as inflammation. And on long-term use, it might be helping in reducing the fibrosis. As far as the clinical effect of this drug is concerned, there has been various trials which has been published or which has been presented in various international conferences. One of them was in 2019 ASLD. It is a phase 2 trial looking at the safety as well as the efficacy of this compound in patients who are having NAFLD. And here they use the MRPDFF, which is the best way to detect the evidence of fat in the liver. And the author has found the reduction in the MRPDFF value in patients where this has been used, and apart from the reduction in the lab parameters. In our department, next slide, please. In our department at our college, we have used this compound in around 64 patients who are having clinical evidence of NASH and FLD. Some of them were also having diabetes as well as other dyslipidemia. And here we use this drug for around 12 months, and we have shown the improvement in lab parameters, including the lipids, triglycerides, as well as the liver enzymes. And also there was improvement in LSM values based on the FibroScan. Next slide, please. There has been, next slide, please. Another abstract which has been presented last year in ASLD, which was a randomized controlled trial. The previous two trials were just the direct trials. They were not regimen randomized controlled trials. This one is a randomized controlled trial, 16 subjects, where they used this drug predominantly in group where those who are having steatohepatitis, the clinically proven or the biopsy proven steatohepatitis. And they have shown after the use of this drug for 24 weeks in the dose of 4 milligram daily, significant reduction in the inflammation, ballooning, as well as improvement in fibrosis, apart from improvement in lipid profile. Next slide, please. So this drug has been approved in our country for treatment of non-cirrhotic NASH in March 2020. And this is also going to be approved in NASH with comorbidity this year also. It's a good compound in origin. Thanks.
So we have just shown that how clinically this could be very useful in decreasing the lab parameters for liver necroinflammation and also the LSM levels, which you have seen in your study. It's a very, very important method by which we have it. So there was a trial which was done all over the country with Dr. Sareen and Dr. Nijaman to be there. And what is the role of saraglitazole in treatment of NASH? Kindly summarize the findings of our collaborative study. Does saraglitazole have effect on the necroinflammation only, or it has effect on the fibrosis? Dr. Nijaman, please.
Yeah, actually, I was part of this trial. As has already been touched upon by Dr. Dadich, there are various international trials which were done on patients of NASH, and it has been shown to be effective in patients with proven NASH, and if they are associated with diabetic dyslipidemia. Now it has been approved by DCGI also, And this is the prospective multicentric double-blind randomized controlled trial in which actually saroglitazar 4 milligram once daily was compared with placebo in patients with NASH. This was done in 10 centers all over India, and our center was one of it. And it has been, can we go back to the previous slide? Yeah, it's basically, there were 102 patients, biopsy proven NASH without cirrhosis, and it was a 52 weeks trial. Next slide. So out of 102 patients, 2:1 distribution between the drug and the placebo. And it has been clearly shown that there was decrease in necroinflammatory score without worsening fibrosis. So it was both. Basically, these are the patients with early fibrosis. So it was shown that necroinflammation was reduced, as well as there was no worsening of fibrosis. Or at least the progression was not there, though it has not been proven whether it decreases fibrosis, but the progression was not there. Next slide. And if you go to the AST, ALT levels and GGT and ALP, and it has been shown compared to placebo, all parameters of liver function got better significantly statistically as compared to placebo. Next slide. And as has been pointed out by Dr. Dadish, that even the lab parameters in their study, which they have done in their center, here also the lab parameters, the triglycerides, HDL, LDL levels, they got better during the course, though it was not the primary endpoint which was there, but there were few patients who had actually dyslipidemia, and that got improved in a trial which actually lasted 1 year. So based on all this, as it improves the necroinflammation, it improves the liver functions, and it improves the dyslipidemia. So it has been actually, approved by DCGI for treatment of NASH, proven NASH in patients, in Indian patients.
Thank you, Dr. Nijaman. Yes. Yes, please.
Yeah. Go ahead, sir. Yeah, go ahead, sir. This has been already said by me. Yes.
Okay. So what I want to just put it forward here, that saroglitazar is one of the drugs which has been developed in India, and one of our companies has done very extensively studied, and at least it shows necroinflammation. We'll talk a little bit later that if you see the progression of the disease, it is a fat leading to fat necroinflammation, and then the fibrosis comes. So if you can halt the progression of NASH by the various actions of this drug and dual PPR actions, you can certainly reduce the lipid in this liver and also the inflammation in the liver. So progression would not be increasing once you are using it for a little longer time. It's a 96 weeks study, 52 weeks study, which has shown this. So it's a very potentially useful drug for the treatment of patients with NASH. And it is going to be very good in the armamentarium of all physicians. So a new drug which has come on the horizon, which is probably acting on the fibrosis, because some people think fibrosis is more important, and this is the guiding force. So this obeticholic acid has been found to be useful in patients with NASH. Dr. Sharma Sahab, would you like to enlighten this thing?
Well, the obeticholic acid is a new farnesoid receptor agonist derived from the chenodeoxycholic acid. Though at present it is not approved for the treatment of NASH, but there are two important trials. It has multiple actions, beneficial effects on the liver. It increases the insulin sensitivity, and it also modulates the lipid metabolism in the liver, lowers free fatty acid, and also synthesis in the muscle and liver. There is a hepatocyte protection against the bile acid-induced cytotoxicity, and there is anti-inflammatory effects. There are multiple effects which are protective to the liver, and there is decreased activation of hepatic stellate cells and prevention of the hepatic fibrosis. There are multiple actions. Actually, there are two trials which are going on regarding the use of this farnesoid receptor agonist in the treatment of NASH. One is the Flint trial, in which 283 patients were enrolled, and this is ongoing trial. And after 72 weeks, it was found that there is an improvement in the NASH by more than 2 points with no worsening of the fibrosis, and there is a fibrosis improvement and no NASH worsening. So this was found to be effective. Next. Further extension of this trial, that is regenerate trial. The interim analysis of this trial are available, and it is a phase 3 study of obeticholic acid for the NASH. Next. So this is also, in this trial, it was also found that it improves the fibrosis by more than one stage or resolution of the NASH without worsening either fibrosis or worsening of the NASH. So this, this molecule is found to be significantly effective in patients with NASH in interim analysis. So the most common side effect, next. The most common adverse effect was pruritus, which was seen in the 19% patients, in the and 28% in group taking 10 milligram and 25 milligram. And in 25 milligram group, 51% had the itching or pruritus. It was mild to moderate, and there is an increase in LDL levels. So there is a cardiovascular concerns about this treatment, but it has been found that giving 10 milligram of statins, that will prevent the development of the cardiovascular complications. Next.
So very importantly, you have mentioned that this obeticholic acid is again a new drug which is coming for the treatment of NASH, and probably the fibrosis is going to be reduced. The other interim analysis is going on, which tells that probably it acts on the various necroinflammatory parameters also and reduces NASH. So it is a new drug which is yet not been approved, but probably it is going to add to our armamentarium treatment. We commonly use ursodeoxycholic acid. Dr. Anurag, everybody of us prescribe ursodeoxycholic acid. What is its role in NASH?
So irrespective of whatever, I mean, UDCA still deserves a mention here. And so I appreciate that this question has been brought up. We all see that whenever there is transaminitis, somehow, somewhere, someone gives UDCA. But coming back to NASH, so UDCA is known to have cytoprotective effects and immune modulatory effects. And it's been there for almost more than 2 decades now. Multiple open label studies initially showed some benefit. Whether you use 15 milligrams or 30 milligrams, it does not make a difference. However, we have now large randomized controlled trials of even up to 2 years, which have clearly shown that they are safe, but they are no better than placebo. And therefore, ASLD 2018 dogmatically writes UDCA is not recommended for treatment of NAFLD and NASH. Thank you, sir.
I think wonderfully brought forward that this is not very useful, but we are all tempted to use it whenever we see ALT and AST elevations in a patient who is obese and who presents, because we do not have many drugs in our armamentarium, and we fail to stimulate or inculcate the habit of exercise and weight reduction or diet reduction in all our patients of NASH or NAFLD. So we probably will have to give lot many combinations like this for treatment of the NASH. But today we come to know that no drug is very useful. So we cannot draw an algorithm for treatment of NASH, because all drugs which we have talked about are still not been proven very effective in the treatment of NASH. If you have any patient of NASH or patient with cirrhosis with the NASH not decompensated, go for the lifestyle changes, give them vitamin E. You can use UDCA in some of these patients. Certainly will bring down the ALT and AST, may not improve the steatohepatitis or the fibrosis, but it is very useful. So there was a very important debate which was just held, and one was saying treat the liver, other was saying treat the metabolic syndrome. One was saying treat the fibrosis with various drugs, but there are no many drugs which are available. And you have to treat the metabolic syndrome. So Dr. Arun Sanyal was of the opinion NASH is not a primary liver disease, but it's a victim of extrahepatic circumstances caused by diet-induced obesity, resulting in metabolic overload, leading to systemic inflammation and fibrosis, impacting multiple key end organs, and steatohepatitis develops in liver. Ultimate end goal is to treat the patient or not just the liver. So we have to treat the metabolic syndrome, which is affecting the liver. And he has tried to analyze with the GLP-1 agonists, which have been used and have been just talked about. And they say that probably NASH resolution is going to come with the use of GLP-1s. All our internists are very well aware of the GLP-1 agonists, and they are using, and one of the drug is semaglutide that increases NASH resolution in 58% of patients with the stage 2 and 3 fibrosis. There is a dose-dependent trend for fibrosis reduction in semaglutide. This is a Newsome has just shown in his study. So GLP reduces all-cause mortality by 12%, and hospitalization and heart failure in 9%, worsening of kidney function in 13%. So this is a very, very promising drug, semaglutide, which is very, very useful. So in NASH management paradigm, we should act on the metabolic syndrome and treat the obesity, treat the diabetes, treat the other parameters of the metabolic syndrome. This is going to improve the quality of life, morbidity and mortality, the functions of the person, and the cost of the treatment also. So weight reduction, diet and exercise holds the key in the management, and whatsoever way you use, you should reduce your weight and you reduce your diet. So international run for NASH treatment. So diet and exercise and lifestyle modification is always a winner. The very close to this is seraglutide, which is progressing. The obeticholic acid and other drugs which are being used are really not reaching to the finishing line. So we have to concentrate on this particular thing. And gastroenterology May issue of 20 has shown this diagram that how ardent is the process of MAFLD or NAFLD, where you have to act very rightly to decrease the metabolic inflammation with healthy eating, exercise, and medical therapy, and prevent the metabolic inflammation in this person and liver fibrosis, CVD, and cognitive decline, which is occurring in these group of patients by healthy eating, exercise, and medical therapy. So this is a very, very important thing which is there. So now we have to come to the point that we have to break the silence on NASH, that NASH is not to be ignored. Metabolic parameters have to be improved by diet, exercise, and few of the drugs which we have in our armamentarium. Thank you very much for participating in this very, very important discussion. I thank my chairpersons, Dr. V.D. Maheshwari Saab, Dr. Puneet, and Dr. Pushpendra Garg for chairing the session. Now, and all my panelists who have worked very hard to bring out various salient features in treatment of NASH, diagnosis of NASH, and how we should break the silence on NASH. Over to Dr.
Manish.
Puneet. Dr. Puneet, please. So, Dr. Manish, would you like to conclude the session?
Thank you, sir. Sir, I just wanted to share a slide and wanted to invite all the esteemed panelists as well as all the delegates.
Share it. Just 1 second.
Sure, sir. So, meanwhile, the sharing is stopped. So, I am Manish, and I would like to thank each of the esteemed panelists and the attendees for making this program well attended. Before concluding the meeting, we have one question also, and before even taking that question, I would just like to invite each one of you for a very, very again scientific rich program on the International NASH Day, which is in association with the Indian National Association of Study of Liver and the Global Liver Institute and Zydus. We are bringing this on the eve of International NASH Day, and it's going to be a jam-packed, very, very exciting session with the with a very important debate, that is lifestyle versus the pharmacotherapy. So before concluding and maybe proposing a vote of thanks, I would, if the panelists wanted to take the question, because we have one question from the audience. The question is from Dr. Harsh Udawat, that fibroscone score of 12, overweight patient, rest all tests including USG abdomen normal, triglyceride normal, LDL 180 milligram per deciliter, probably familial, recently diagnosed, well controlled hypertension. What do you suggest, lifestyle intervention or the drugs?
There's a discordance between the presentation of fibrosis and absence of other features. So I think this patient actually deserves a liver biopsy. And then we have to actually pinpoint the treatment. So it's not only non-medical treatment which will be important, but here is the case where you want to prevent the fibrosis and ongoing nectar inflammation, which can lead to progression to cirrhosis. So it's in this, as an individual case, we should go ahead and do a liver biopsy and do further treatment.
Very rightly pointed out that inconclusive patients, inconclusive parameters.
Hello. Sir, can I add on?
Yes, sir, please.
We can also, because these values are dynamic. Today it is 13, maybe a few months later or 2 months later, it may come down. So ask the person to change the lifestyle and a repeat test after a few weeks or so. And then you can decide about the liver biopsy, because biopsy being invasive, and these non-invasive tests can be repeated as number of times. So the middle path is to ask him to change the lifestyle and then repeat the test after certain, maybe a few weeks, 4 weeks or 6 weeks. And if there is a change in any values, because 13 is the only thing which is discounted and rest other things are all okay, and go for other tests to look for liver fibrosis. Other non-invasive tests apart from fibroscan, the blood parameters, as well as if we can afford the MR and other. Then
it has been shown in the algorithm that if there is a discordance, you have to decide what is right and what is wrong.
Yes, you have to decide.
But middle course is always good, but nobody would like to get a liver biopsy done himself. So we have to ask him to change his lifestyle and improve his diet and improve his weight and things like this, and then again do it again. And because it is not it's a smoldering disease, so may not be that he requires liver biopsy on day one. We can still go ahead and not treat, but change the style of this person. Dr. Manish?
Sir, there is another question from Dr. Deora. In case if the panel is open to take this question, so I'll just probably the last question of the day to end up. So the question is, do statins have any role in prevention of NAFLD in high-risk cases like metabolic syndrome, obesity, and type 2 diabetes? And he further on adds that many a times also the lipid values are normal in many patients. Do still giving a statin in these patients will help them?
Anybody taking up? But my opinion is statins are useful if you have hypertriglyceridemia or hypercholesterolemia and HDL is low. Probably this group of patients will need statins. But there is no study as such to say that if all parameters are normal and you give statins to these persons and his NASH or other things are going to improve or not improving. So statins have a definite role in reducing the metabolic parameters or metabolic syndrome, but it is not useful as a candidate drug for the treatment of NASH.
Very right.
There were few trials earlier with the simvastatin, I think, in liver cirrhosis, where they have shown the use of simvastatin acting as an anti-inflammatory and anti-fibrotic agent, and there was some improvement in liver fibrosis as well as inflammation. So those were the earlier studies. and study has not been done with the commonly used and statins like atorvastatin or rosuvastatin. The study was with simvastatin, which is not being used in clinical practice.
Very right. Very right. So, Dr. Puneet, are you there? Dr. Puneet? Okay. Dr. Manish, would you like to?
I would like to again thank each one of the panelists, the Gastrohepato Foundation, as well as the Association of Physicians of India, who has provided this valuable platform to the organization and to the audience for such a enriching experience and in-depth discussion in the management of NAFLD and NASH, understanding the disease in detail and also what are the key challenges as a physician to bring providing the right kind of treatment to the patient. I would finally hand over to the chairpersons to conclude the meeting.
Professor Maheshwari, please unmute yourself. Yes.
Yeah. Thank you so much, Dr. Ruprai, your foundation, and all learned panelists. Very, very enlightening discussion. Though discussion was low, but you covered all the topics starting from incident, treatment to the core. Very important topic in today's time. And we see that diabetes, metabolic syndrome, hypertension, after all, they have common denominators. And liver disease. All of them have common denominator and common, factor as lifestyle changes, which are causing all these things. So I think you addressed the topic so well, and newer, drugs which play a role in NASH, which are likely to come up. So we'll have more and more drugs in our armamentarium. Till then, all of you have emphasized lifestyle modification. That's a very important thing. Thank you so much for enlightening discussion. Thanks a lot.
Thank you very much to all my chairpersons and all my learned colleagues in the panel. Thank you very much for joining.
Thank you.
Thank you.
Thank you, everyone.
Thank
you, everyone. Thanks a lot.
Good night. Stay safe.
Thank you, sir.